Welcome to the Leukemia and Lymphoma Society of Canada's webcast called New Treatment Horizon, Chimeric Antigen Receptor CAR T Cell Therapy. In this presentation, Dr. Kevin Hay will speak about one type of immunotherapy involving engineering patients' own T cells to have a unique receptor called a Chimeric Antigen Receptor, or CAR, enabling these immune cells to recognize and attack cancer cells. We will learn how a CAR T cell is made and how it works, as well as the current and future indications for this novel therapy. My name is Sonia Muto, Community Program Coordinator for the Leukemia and Lymphoma Society of Canada. I will be the host of this online event. During the webcast, you will hear only my voice and the speaker's voice. Since there are many of you, questions may be asked at the end, but only online using the question or chat function. The presentation will last approximately 45 minutes and will be followed by a 15 to 20-minute question period. The presentation is also being recorded. Therefore, you will be able to listen to it again on our website while following along with the PowerPoint presentation. We will send you an email when the recording is available. Our mission is to cure blood cancers and improve the quality of life for patients and their families. We offer support to people affected by blood cancer every step of the way. Please reach out to us if need be. We have several informative tools, such as fact sheets and booklets, available on our website, llscanada.org. We also have a series of educational videos accessible on our website. It is my pleasure to introduce our speaker, Dr. Kevin Hay. He is a clinician scientist at the Terry Fox Laboratory and Leukemia Bone Marrow Transplant Program of BC, assistant professor for the Department of Medicine at the University of British Columbia, director of the Clinical Cellular Therapy Laboratory at BC Cancer, and medical director at the Conconi Family Immunotherapy Laboratory at BC Cancer. Over to you, Dr. Hay.
Thank you very much for your kind invitation to present to this national audience about what CAR T cell therapy is and some of the research that is being done here in Canada. So I'd like to first of all introduce people to the idea of what chimeric antigen receptor CAR T cell therapy is and why we use this therapy in order to treat some cancers. So the basic method behind why this works is that T cells are a vital part of our immune system that everybody has. It recognizes abnormal cells in the body. Now, in typical individuals, this is typically early cancer cells or virus-infected cells, but in people who develop actual full tumors that develop into cancer, the cancers basically have developed mechanisms by which they evade the killing that the T cells perform in order to keep those cells under control. And so what chimeric antigen receptors do is they are modified receptors for these T cells that now enable these cells to recognize the cancer again. So the way CAR T cells are made is we first of all have a patient who has a particular disease like a leukemia or lymphoma, and those cells are isolated from the patient through this process called leukapheresis. So they basically sit on a machine, and anybody who's done a autologous stem cell transplant would understand this process. Basically, those cells are isolated from the patient's body, and the rest of the blood is returned back to the body. And then those cells, those white blood cells, are taken to the lab. And then in the lab, the CAR itself, that receptor, is introduced into those cells using actually a viral technique so that this gene actually gets inserted into the cells. Now, I say a viral technique as opposed to necessarily a virus, because the viruses that are used are what we call inactivated, which means they aren't able to replicate or cause any disease. They're simply used as methods to carry the payload, so to speak, into those cells. And so it gets put into the cells using this technique, and then those cells are grown and expanded outside the body over a period of about 10 to 14 days or more, and then subsequently reinfused back into the patient. Now, prior to the reinfusion of these cells, we use chemotherapy to prepare the body to receive these CAR T cells. And the reason why is because there were previous studies that have been done with CAR T cell therapy where if we do not give the chemotherapy before it, the CAR T cells do not seem to function as well, and they don't seem to persist as long in the patient's body. And this can lead to some decrease in the efficacy of the therapy. So the chemotherapy portion of the CAR T cell therapy kind of package is actually very vital to allowing the CAR T cells to work efficiently. So after these CAR T cells have been infused in the patient body, you can see this blue curve I have on the slide that shows basically what is happening with the level of CAR T cells in the patient's body after the infusion. And you see the peak there, that typically occurs about 10 to 14 days after the CAR T cells have been infused into the body. And then the subsequent decline occurs over another 2 weeks. But the idea is that it reaches a bit of a plateau near the end, where these T cells can now act as a surveillance mechanism, basically, to prevent relapse of the cancer coming back again. And you know, there are people looking at various different ways to increase that persistence for longer. And it's unclear, though, how long that persistence is needed at this stage or how vital it is for different diseases. For example, in ALL, acute lymphoblastic leukemia, that persistence appears to be very important, whereas in something like non-Hodgkin's lymphoma, like diffuse large B-cell lymphoma, we don't necessarily maybe need that persistence as much. What we maybe need more in that case is a larger peak, a larger kind of area under the curve there, a bigger sledgehammer, so to speak, to actually put the cancer away. So one of the big difficulties with CAR T cell therapy is that it depends upon us identifying a target for these CAR T cells to recognize the cancer. And so this target needs to be something that's on all cancer cells and on the surface of all those cancer cells so that it's accessible for the T cell to see it in the setting of a CAR. And in addition to this, since this is something that could also potentially target other cells, it would be ideal that it's not present on non-cancer cells, or that absence of those normal cells is actually very tolerable and manageable. And so this is what makes CD19 CAR T cells so important and such a good target, because CD19 is it's a protein that's on the surface of all of these cancer cells for ALL and CLL and diffuse large B-cell lymphomas, but the only other cell in our body it's really on is on our normal B cells. And so although B cells are important, they're not essential for life. And so that's what makes CD19 CAR T cell therapy for B cell cancers so easy, comparatively speaking, to developing CAR T cell therapies for other cancers. So this is one of the big hurdles that is preventing us from kind of going forward a bit more in CAR T cell therapies, but we are definitely working on that into the future and identifying better targets. So it just so happens too that those B cell cancers that I've mentioned, like acute lymphoblastic leukemia, or ALL as I'll say it from now on, or diffuse large B cell lymphoma, these are therapies that in patients who are relapsed refractory and have failed, really, who these therapies we've had so far have really failed them, we really need better therapies, because those patients with ALL, for example, if they have, if the therapy has 2 lines or more have failed, the overall survival for those patients, as you can see from these curves here, which are demonstrating as patients unfortunately die, the overall survival is less than 6 months for 50% of these patients. And by 2 years out, only about 10% of patients are still alive. And same thing with diffuse large B-cell lymphoma. And this is again in the setting of where patients have already undergone 2 previous lines of therapy and the therapies have been unsuccessful to control the disease. The overall survival is only about 6 months in this setting when you look at the average, the median. So if you look on these curves, I don't know if my pointer shows up here, but you can see at the 0.5 mark on both of them, that's where I'm talking about the median occurring and about how that's occurring really at about 6 months. But then if you look at it, it continues on to the point where at about 2 years in diffuse large B-cell lymphoma, again, only about 20% of patients are alive in this setting. And I just wanted to mention again that that's really in the relapse refractory setting. That's not in terms of upfront therapy for lymphoma or leukemia, just to keep that clear in everybody's mind that those outcomes are much better for the majority of patients. So what about CD19 CAR T cells in B-cell ALL? Well, I'm just showing here that there's a lot of evidence in the literature now, the scientific literature, demonstrating that these therapies have been successful. So this is an example from this paper was published from the group at University of Pennsylvania, this one from the NIH group in the US in Bethesda, Maryland, this one actually at Fred Hutchinson, which is the group I worked with, and this one here from Memorial Sloan Kettering in the US. And in all of these trials, basically 75 to 85% of cases had no remaining disease detectable after receiving CAR T cell therapy with CD19 targeting. And so this is where these patients who are highly relapsed refractory had a survival average of probably less than 6 months. Now we're able to completely clear the disease so far as we can detect it in about 80% of these cases. So this is really unheard of kind of efficacy at this level of therapy. So that led to obviously quite a lot of excitement in terms of the treatment of these cancers. And then you look at in the setting of diffuse large B-cell lymphoma, and here's 2 pivotal trials called, one for a product called Antigen lecalucil, and the other one called Antigen cytolucicil, which are a bit of a handful to say, but basically these are 2 different CAR T cell products. And in both of these papers demonstrated that in patients whose lymphoma, whose diffuse large B-cell lymphoma hasn't responded to 2 or more other lines of therapies, these CD19 CAR T cell therapies have had very impressive results where we've been able to completely eradicate the disease in about 50% of cases compared to historically, as I showed you from that previous slide, that curve, it was only about 7% of patients actually were able to have their disease be under control. And most of those patients who have been able to achieve what we call a complete remission, where we can't detect any more disease, most of those patients, about 60 to 70% of them, are still cancer-free at this point. Although I must say that follow-up is relatively short at about 2 years or so now. But it is very suggestive that we may have been actually able to cure some patients in whom other therapies have failed to have efficacy. So these are the 2 commercial products I'd like to mention that were reported in those papers and just what their indications are. So the Antigen lecalucil, or Chimeric, is its indications that are approved are for B-cell ALL from the ages of 2 to 25 years old and adults with diffuse large B-cell lymphoma. And the Yescarta, or Antigen cytolucil product, is for adults with diffuse large B-cell lymphoma. You can see they've already undergone FDA approval, and they are also Health Canada approved as well. And then there's a third product by another company called Juno, which has been taken over by Celgene, which was taken over by another company, but it's called Lysocaptogen maraleucel. And from my understanding, looking on what has been happening, they're intending to file relatively soon with the FDA in the last part of this year. So this obviously has led to a lot of hype surrounding these therapies, where you can see on the top left, the American Society of Clinical Oncology named this in 2017 the #1 advance of the year. And then the New York Times has also been excited about this, putting out articles on setting the body as serial killers loose on cancer. The Economist as well has talked about Mr. T cell being the way forward to fighting cancer. And you can even see that this is developed into the Twitter world, where it's noted when Novartis has received Health Canada approval of its CAR T cell therapy, and there's multiple different Twitter announcements all the time about what is happening in CAR T cell therapy. Personally, I myself don't follow Twitter, so it's a bit, I think it's a bit hard for me to keep up with everything, but if you kind of search it quickly, you can find a lot of different posts or tweets, I guess they're called, on Twitter about CAR T cell therapy. So that's all the hype, but what is actually the reality? What is the reality for patients undergoing this therapy? And in particular, what are the side effects? And what are the chances of the leukemia or the lymphoma coming back? Because as I mentioned, it's pretty good in some cases of getting rid of the lymphoma or the leukemia entirely, but what are the chances that it would come back again? And then I also want to touch briefly on why we don't have these products readily available in Canada yet, and what we're doing about getting those products for patients, and also touch a bit on why we don't have this for other cancers yet. So in terms of the side effects of CAR T cell therapy, the ones that are obvious to point out are, first of all, that, as I mentioned, chemotherapy is necessary to allow those CAR T cells to work efficiently. And until we develop a mechanism to not require the chemotherapy aspect of this, chemotherapy-related side effects will be a part of the CAR T cell therapy package, basically. And so that means, patients will experience low blood counts, nausea, vomiting, all those typical kind of chemotherapy-related events and side effects. But, as a community of oncologists, we have really gotten quite, good overall, I would say, about managing chemotherapy-related effects, although one could argue we could always need to do more, obviously. But that's not really been the major concern of CAR T cell therapy. So the other one I'll mention is, as I said, normal B cells are targeted by this therapy as well. So you get what's called B cell depletion in patients who have responded to CAR T cell therapy. And the B cells are the cells in your body that are responsible for producing antibodies and to produce new different types of antibodies in the response to certain stimuli. So, for example, when you get your flu vaccine booster, for example, as you do every year, your new flu vaccine, it is the B cells that respond and are able to make new antibodies against the flu virus, so that when you do get exposed to flu, you have some antibodies that can mop up all the flu virus and get rid of it before it causes you significant harm. So B cell depletion, although, B cells, although, as I said, they're good for your body, they're not 100% necessary. And this B cell depletion does appear to be fairly well tolerated in patients with no long-term side effects. And the B cells do eventually recover after a period of time, after those CAR T cells have gone away in some patients. And even if they haven't gone away, if patients are experiencing multiple, infections that are related to lack of antibodies, we can provide patients with antibodies in the form of something called IVIG, or intravenous immunoglobulin, which is basically where, healthy donors have provided their antibodies to the blood service, and then those antibodies can be infused into patients. And we've done this before for patients who have, congenital issues with having their B cells, and it appears to be very effective. The main ones I want to talk to you about are these CAR T cell specific toxicities. that have really been discovered after we've been using CAR T cells. And the two are cytokine release syndrome, or CRS as I'll call it. And the second one is something that's a bit of a word mash here. It's immune effector cell associated neurotoxicity syndrome, which is also known as ICANs. And so I'll go into a bit more detail now about both of those. So what is CRS, or cytokine release syndrome? It's basically an overactivation of the immune system. So if you could imagine, somebody who gets the flu, they get the flu and they start to feel a little bit unwell, kind of muscles achy and sore all over, and fever. So that's like the first stage of CRS. Patients experience that. And then what can happen in patients, some patients who develop the flu, is that they can get so sick they need to end up in hospital. And in some cases, it can lead to problems of low blood pressure and failure of organs and lead them into the ICU. And it's the same sort of way with CRS, where basically you can initially develop this fever and kind of flu-like symptoms, but then it can progress to the point that your blood pressure is very low, and we need to give you medications to help support your blood pressure called vasopressors, which can only be safely given really in an ICU setting. And a lot of hospitalization, and it can lead to basically organ failure. So it's called CRS because really the things that we think are causing this overactivation of the immune system are all these cytokines, which are molecules that are of the immune system that it uses to communicate in the body, leading to these symptoms. So it's when the T cells are recognizing the cancer, they're releasing these cytokines, and then they're activating other cells of the immune system, particularly, if anybody's interested, macrophages and monocytes, to create more cytokines, and it makes this massive feedback loop that kind of gets out of control. And that's really what leads to this CRS event. Now, there's probably some difference in CRS rates depending upon what CAR T cell product is used, but since nothing has been compared so far head-to-head in trials, and a lot of the trials have been done using different grading systems for CRS, it's difficult to compare directly, but it occurs in roughly 70% of the time where you get those fevers and flu-like symptoms, and the more severe cases of where you're needing some blood pressure support occurs more on the order of 7 to 40% of the time. Again, that 40 is probably a higher estimate. It's probably more like 7 to about 20, 25% of the time. And how about this other thing I mentioned called ICANs, or immune effector cell associated neurotoxicity syndrome? Well, it's basically something we discovered early on with CAR T cell therapy, where basically anybody can have almost any symptom of the nervous system being affected by these CAR T cells. We're not exactly quite clear on what drives it entirely at this point, although there is some research that we've done from my previous work when I was down at Fred Hutchinson about how it may have to do with some blood-brain barrier disruption. So your blood and your brain is normally separated by this membrane that basically does a good job of making sure that your brain is only exposed to what it needs to be exposed to, and that barrier can be broken down in some people. And we think maybe the CRS and everything that happens leads to a bit of a breakdown in this blood-brain barrier, which then contributes to the neurotoxicity. So you can see I have listed in this table a bunch of different changes, neurologic changes that have been noted to occur with CAR T cell therapy. So it's a long list, but the main point is it really causes a lot of cognitive changes, changes in level of consciousness, confusion, disturbance in attention. In some patients, it can cause hallucinations, agitation, restlessness, irritability, headaches, migraines, anxiety. Some patients, it leads to something called aphasia. So this is where somebody has difficulty speaking, and can also lead to what would be like motor dysfunction, where patients can have a muscle weakness. So it's like suddenly their right arm goes completely limp. And automatically you would think of those patients, oh, they've had a stroke. But when you scan their brain and do all their tests, it's not actually a stroke. It's actually due to the neurotoxicity. And this is possibly a part of the CRS spectrum, or at least associated with it. And it occurs in around 40% of patients, but is more severe in about 10 to 30%. So in terms of the timing of when these side effects tend to occur, they tend to occur somewhere in the first 2 weeks after CAR T cell therapy is usually their onset. So CRS usually has its onset before the ICANS does. So you can see I've separated them out a little bit in terms of when they've started. And so they kind of start somewhere around day 2 to 5-ish or so usually, but then reach a peak in severity and then come back down again and go away. And this is just kind of on average that I'm demonstrating on this slide. But what's interesting too is that there's a period where people don't have very severe symptoms yet, where we have this kind of window of opportunity to intervene with different targeted agents to try to control these side effects in time before they get more severe. So those rates I'm mentioning to you that of all those severe rates have really been coming down in the past few years because we've been better able to treat CRS and ICANS up front sooner to try to really limit the severity of these toxicities. So how do we treat these side effects? So the goal of the therapy here is actually just to shut down this excessive cytokine production and to block those cytokines from causing further damage to the body. So what was discovered fairly early on is that there's this one cytokine called IL-6, or interleukin-6, which appears to be fairly important in this cytokine release syndrome. And so it was actually the group at UPenn who tried this first, and they used this antibody called tocilizumab that blocks the receptor that IL-6 binds to. And we discovered fairly early on that by blocking this pathway, we can very quickly reverse some cytokine release syndrome in patients. And so that's one of the mainstays of ICANS and CRS therapy. Now, you can see on the right-hand side there, I'm describing kind of what we do at different stages. So when patients initially just have a bit of mild CRS where it's just causing some fevers, we just do what's called supportive care by providing Tylenol, providing care. They need to stay in hospital because their blood counts are often fairly low at this time, and we need to cover them with antibiotics in case this may be an infection, similar to something called febrile neutropenia that people might be familiar with already. So that's always another possibility that it could not be CRS, it could be febrile neutropenia. So we treat it as if it's both basically for a little while. And then if it gets to the point where it progresses where the blood pressure starts to drop and we need to get some fluids in order to keep that blood pressure up, that's when we really intervene with the tocilizumab. And then we add on the steroid therapy if the tocilizumab alone is not working, because steroids are like a massive suppression of the immune system in general. So they'll really help control those cytokines, and also they'll help calm down those CAR T cells. Initially, there was some concern that if we threw lots of high doses of steroids at patients, that we'd actually be shutting off the CAR T cells too much. But as we've gotten more comfortable with administering this therapy, we've started to realize that that concern is not very well founded, and that we really should probably be using steroids earlier when patients are experiencing these side effects. And so steroids also are more helpful probably than tocilizumab for controlling that thing called ICANS, because tocilizumab doesn't seem to work as well for ICANS. It works very well for controlling CRS, but not as well for the neurotoxicity. The steroids really do a lot of good for that. Now, what's interesting is I may have scared you with talking about all these side effects and toxicities and something that looks like a stroke, and really it is very scary for patients to undergo this, and especially for their families too, who are seeing them undergo these neurotoxicity events. But I would need to state here that the vast majority of patients over 95% or more, respond very quickly to these interventions, and there does not appear to be any long-term side effects, be it neurologic side effects or otherwise. So just moving on now to that second question I mentioned. So what is the chances of, my leukemia or lymphoma coming back after CAR T-cell therapy? And so I'll just show you some of the data we have so far on this. So I unfortunately didn't put the reference here for my slide on the left-hand side, but this is from something I just published this year from some of the data from Fred Hutchinson, and the one on the right is from the paper regarding the Antigen cytolucil therapy, the CAR T therapy for diffuse large B-cell lymphoma. So I'll first of all focus on the diffuse large B-cell lymphoma side there. So that slide, that picture you see there, it's what's called a Kaplan-Meier curve. And what this means is that as the curve drops down, that means patients who are falling off the curve. So they're having what's called an event. So that basically means that somebody has had a relapse of their lymphoma. So as the curve goes down, that means patients are relapsing. And what you ideally would like to see in any therapy is a line that just goes straight across at 100%. But what you're seeing here is that patients who have only a partial response to CAR T-cell therapy as their best response almost uniformly eventually relapse after CAR T-cell therapy. So really, in diffuse large B-cell lymphoma, you really need to hit it hard with a big sledgehammer, we think, because those patients who still have some disease kicking around very rapidly will progress kind of basically within the first 2 to 3 months after receiving CAR T-cell therapy. However, those who've attained what's called a complete response, where there's no disease detectable after CAR T-cell therapy, seem to have a fairly good long-term outcome in the sense that once you get out to about 12 months here or so, you can see this curve reaches just a straight line, a plateau, suggesting that patients, once they've gotten to that 12-month mark, may actually be in the clear. Again, as I mentioned, it's a bit early to say that definitively, but it's highly suggestive of that and has led to a lot of excitement that some of these patients who were previously deemed incurable have now been potentially cured by this. However, there are those 30% or so who drop off the curve. And so we really need to do better at treating those patients. And that's what some of my research is focusing on as well, is trying to understand why patients are suffering relapse. So that's some of what I've been working on in my lab and trying to make therapies that are better at keeping patients in remission. So when you look on the left-hand side here about patients with B-cell ALL, you can see again this aspect that those who obtain what's called an MRD negative CR, this is that state of where I said you can't detect any disease whatsoever, they do much better than those who have no response after CAR T-cell therapy or very minimal response, as can be seen here. But again, there's a lot of patients who unfortunately relapse, and that relapse again tends to happen within the first year after CAR T-cell therapy, and then the line tends to become more of a flat line after that point. So, relapses unfortunately do occur. They typically happen in the first year, but, there is some suggestion that we may be reaching a point where we've achieved a cure after a year in some patients. And much research still needs to be done about preventing relapse. One important thing I'll note for ALL, there's a strong debate ongoing right now about whether patients need to proceed on to what's called an allogeneic stem cell transplant after receiving CAR T-cell therapy or not. So some of the work I did at Fred Hutchinson suggests that those patients who have good long-term responses are those who went on to receive an allogeneic stem cell transplant. However, there are other sites in the US that published and said maybe it's not necessary. So what this means is that we don't have enough information yet, and we need to do more research so that we can appropriately advise patients on whether or not they should have a transplant done after CAR T-cell therapy. And I'd urge anybody who's kind of in that situation potentially to really have a good conversation with their hematologist, oncologist about this, because they would be the one best kind of versed in their exact disease and what their needs are. And obviously, from those of you who may have heard about allogeneic stem cell transplantation, it's a very complicated procedure that has a lot of risks and a lot of potential benefits, and that needs to be discussed in the context of discussion with your doctor. So after CAR T-cell therapy, there are still some side effects that can continue on a bit longer than the first month. One of them is that low blood counts are fairly common after CAR T-cell therapy. So rates of, somewhere around 50 to 75% of patients still have ongoing low blood counts for more than 30 days after CAR T-cell therapy. And this may be due to the fact that a lot of these patients have been heavily pretreated with a lot of chemotherapies, so it takes a long time for their bone marrow to recover. But it also seems to be linked to the grade of CRS they get. So if they had a high grade of CRS, they have a longer duration of these low blood counts. And you can see here on the right-hand side, where those patients who had severe CRS, which is in the red here, their red blood cells are quite a bit lower than those patients, for example, who had only mild to moderate CRS, who had a drop initially in their blood cell counts, but then it subsequently recovered, compared to those who had no CRS. So often what we're recommending at this point is a watch and wait approach. The vast majority of people do recover, but if your blood counts are still low, 6 months or more after CAR T-cell therapy, often that's when the hematologist or oncologist will be a bit more worried and maybe consider looking at a bone marrow biopsy just to make sure that nothing else is going on. So the other thing to mention is that antibodies take a long time to recover in some people, and that's due to that B-cell depletion, as I mentioned, from the CD19 targeting. But it doesn't appear to be associated so far with an increased risk of infection. And as I mentioned, it can be replaced using that IVIG that I mentioned in the individuals who do need it. So one exciting thing about this therapy is that it really, as I've described it, it's a living drug, basically. These cells are still alive in your body and can persist past those first 30 days, and potentially in some patients we've seen them still present after 4 or more years, still going on in the patient's body. So I wanted to share one case example for you. So this is one patient who had PET scans done. That's what you're seeing here. And basically with a PET scan, what you do is you take an image, but before you take the image, you put in this, basically it's labeled glucose. And glucose is something that is basically a sugar that your cells use to really have a lot of energy and to do things. And it just so happens that tumors tend to light up a lot because they really like that glucose, and they really show up as these bright spots on a PET scan. So you can see this one patient with diffuse large B-cell lymphoma before CAR T-cell infusion had this big mass of tumor, diffuse large B-cell, sitting in his kidney. And so that's what you're seeing on the left. And then after CAR T-cell infusion on day 28, we see it still lighting up. And the radiologist who sees this initially says, oh, it looks like there's actually some increase in the size of the mass there, and probably lymphoma, because that's always what I've seen. When it does this, that's lymphoma. But we looked at the blood in this patient and saw that they had actually, out to day 28, they still had very high levels of CAR T cells in their blood. So we said, well, what's going on here? And so a biopsy of that mass was performed, and it actually demonstrated that that mass was essentially all CAR T cells, because CAR T cells are active living cells that need glucose. And so they light up on these scans. And so we performed another image in this patient about a month later and demonstrated that all that big mass is now completely gone. Again, demonstrating that this hypothesis was true, that it really was the T cells that were causing this mass to light up. So this leads to some difficulties in interpreting what is actually a response or not in the initial few months following CAR T cell therapy. So that's why in some patients who have had a partial response after 1 month, they'll often go on to have another scan about a month later or 2 months later to just confirm what is happening. Most of these kind of responses, these ongoing responses, tend to occur within the first 3 months after the CAR T cell infusion. So why don't we have these in Canada yet? So this is obviously a difficult one to answer for people who see these amazing results and want to really have access to them. And so I thought I really need to touch on this and explain the approval process in Canada a little bit. So part of it is, first of all, that things get delayed from the US to approaching Health Canada. And that's a bit on the side of, a lot of these companies are focused on the US market and really want to get their FDA approval before they go on to getting approval in other countries, which is, from that's totally understandable from their perspective. And so, we've achieved Health Canada approval now already, but then after Health Canada, it has to go to this other body called CADTH. And this body called CADTH is composed of a bunch of different people, experts really across Canada who are physicians. I believe patient groups are also involved in this, as well as, health economics, to really say, okay, what is this really, is the evidence for this really that good? Or, is the wool being pulled over our eyes? They really wanted to examine this evidence fully. So it has to go through all this process, and part of it is also discussions around pricing and access, ensuring that everybody in Canada can have access. So one of the concerns that CADTH raised with these products, they raised really two. One was the price of the therapy. The other was related to access in Canada and really making sure that we have good, strong interprovincial agreements so that everybody in Canada could potentially have access to these therapies. And so where it went from there and where we are right now is it's with the Canadian Association of Provincial Cancer Agencies, or CAPCA. And so I believe CCO has been the one, so that's the Ontario organization, has been leading the charge for all of Canada. So they take turns being whoever's leading the charge. And really this group has, I believe, it started to come to some sort of an understanding with at least one or more of these two companies that have products that are Health Canada approved. So we should be hearing something at some point here soon. But until we hear that, we can't really apply these therapies as standard of care inside BC or elsewhere in Canada. I'm mentioning BC simply because that's where I'm sitting right now. So as I said, we are currently at this stage, and many hospitals are preparing and are pretty much ready to go fairly soon after it's finished these stages. And there's a lot of administration that is also involved. So as I said, provincial discussions are ongoing for these commercial products. Centers that will deliver the therapy, though, also need to be very specialized because, as I mentioned, there's a lot of training that needs to happen in terms of how to manage these side effects and toxicities. And there's also the complexity of making this drug, so to speak. It's not something that you just get from the manufacturer and it sits on the shelf in your pharmacy until such a time as you need it. It's something that you need the patient, you need to assess whether they should receive this therapy or not. Then they need to undergo that leukapheresis procedure. Those cells need to be shipped down to the US currently is where they're being manufactured, and then they need to be manufactured there, shipped back again. And so there's this complex chain of custody and manufacturing that occurs. And so centers really need to be certified to be able to administer these therapies. Currently, there is some access within Canada. It's provided really on a clinical trial basis, really, or there are out-of-country mechanisms. through the Ministries of Health, usually in most provinces, whereby if it's deemed that a patient would be appropriate for this therapy that is Health Canada approved, but we don't have it available yet in Canada, the ministry can supply funding to help these patients get the therapy outside of Canada. So this is something that's more recently come on board now that it's a Health Canada approved therapy. So what about other cancers quickly? So CD19 CAR T cells, first of all, seem to be working actually fairly well so far in other refractory B-cell leukemias or lymphomas. So in CLL, for example, about 75% or so respond to therapy in one study of 24 patients, and there's other studies that are showing similar sort of effects. It does seem to work a bit better if it's combined with another drug, which those who have CLL might be familiar with. It's called ibrutinib. So it does seem to be that the combination of those two seems to lead to a better response and actually decreased rate of the CRS toxicity. So, you know, a lot of people are working forward on further clinical trials of combining CAR T cells with ibrutinib. So we should be hearing more about that as time goes on. And in follicular lymphoma, again, these are kind of studies I know quite intimately because I worked on them at Fred Hutchinson. In follicular lymphoma, we published just recently in a small study of only 8 patients who had follicular lymphoma, all had a complete response and all seemed to be really free of disease, still ongoing past 24 months now. So more research is needed in these cancers before they get to the stage of where they might be something that we would call standard of care. But it's highly suggestive that we may have these therapies for other cancers, not just diffuse large B-cell lymphoma and ALL. Myeloma research, as I'll mention as well, that's ongoing and shows significant promise, and other targets are really being explored in this. And then there's a whole realm of solid cancers that everybody is exploring in CAR T cell therapy. So finding the right target there, as I mentioned previously, is one of the major hurdles. But another challenge is that with these solid tumors, it takes a lot for the T cells to penetrate all the way into the deep side of the tumor, and these tumors have developed many different mechanisms to evade the cells and shut them down. So it'll be really challenging, but it'll be very interesting once we actually have some therapies that may be working in solid cancers. So in conclusion, CD19 CAR T cells have demonstrated success in refractory B-cell ALL and non-Hodgkin's lymphoma. CRS and ICANs, these are common side effects that can occur, but are reversible in the majority of cases with appropriate therapy. Relapses, unfortunately, still do occur after CAR T cell therapy within the first year, and much more research is needed into this and trying to prevent these relapses and produce better CAR T cell therapies. Some side effects persist after CAR T cells for a bit longer, such as those low blood counts or low antibody levels, but those do eventually recover over time. And access to CD19 CAR T cells in Canada is currently only available through clinical trial or an out-of-country application. And active research really is ongoing into CAR T cell therapies for other cancers. So I'd like to end with that, and thank you very much for your time.
Thank you so much, Dr. Hay, for shedding some light on CAR T cell therapy. This therapy has definitely been a hot topic in the community, and it's really great that you were able to share some of your expertise with us. We've received quite a few questions. So if you do have any questions, please remember to use the question or chat function to do so. And please remember that we will also be taking general questions. Any other more detailed or private questions, we will do our best to answer offline. So let me go through these questions. So can CAR T cell be used after a stem cell transplant?
So yes, CAR T cell therapy can be used after a stem cell transplant. In a lot of those, what we call pivotal trials in diffuse large B-cell lymphoma, the two I mentioned that really led to their approval, actually previous allogeneic stem cell transplant was excluded from, so those patients weren't included, but in the trials we ran at Fred Hutchinson, they were included. And subsequent real-world data has demonstrated that prior transplant was not a barrier to providing CAR T cell therapy. So yes, it can be done. There's more concern in the setting of the allogeneic stem cell transplant, and that is because the T cells that you're manufacturing into CAR T cells are actually from that healthy donor who donated to you. And so those T cells can sometimes cause an exacerbation of what's called graft versus host disease for those people who are familiar with allogeneic transplant, where the cells start to attack the rest of the body. So that was the concern, but there doesn't seem to be any, based upon the few reports we have so far, there doesn't seem to be any increased risk of that occurring. So it seems to be very safe, but that was the initial concern as to why to not use those, on those pivotal trials.
Thank you. The next question, do we know why, from a mechanism perspective, why chemotherapy enhances CAR T?
Yes. So there are a few things there. So first of all, the type of chemotherapy we give is something that's called lymphodepleting chemotherapy, which means that those chemotherapy drugs we use actually target the endogenous, so the T cells that are already in that patient, still remaining in that patient's body. So what happens by getting rid of those T cells that are there still already in the patient's body is that those T cells are using a whole bunch of basically cytokines and other growth factors that are present in the blood and the bone marrow to keep on growing and to live and survive. And so you get rid of them, and then suddenly all those growth factors, all those things are now readily available for those CAR T cells to come in and use up all those resources. So it's kind of like freeing up resources for those CAR T cells to really work and use to grow and expand very rapidly. So that's one mechanism. Another mechanism is that that lymphodepleting chemotherapy probably also has some degree of anti-tumor effect, and so it shrinks the masses a little bit and causes some of those tumor cells to die off a bit, which may make the CAR T cells make it so the CAR T cells are able to access the tumor a bit more easily. And then the third reason is that the addition of one of the chemotherapy drugs, at least the fludarabine aspect of it, that drug seems to actually increase the persistence of the CAR T cells. And part of that may be due to the fact that in patients who didn't receive the fludarabine in one of the studies we did at Fred Hutch, what happened is that the patient's own T cells in the body, the normal T cells, started to recognize the chimeric antigen receptor T cells as foreign cells and getting rid of them very quickly. And so basically it helps prevent that immune reaction against the CAR T cells from occurring. So there's multiple different mechanisms, and I'm sure there are more that we will figure out as we go along.
Thank you. One question here, does the patient need to be in hospital or in isolation during CAR T treatment?
So that's a good question. That's something that has been debated a bit in terms of whether a patient needs to be in hospital or not. It does appear with at least one of the agents, the isocaptogen maraleucel, the one that hasn't received FDA or Health Canada approval yet, but is working towards that level. It appears like that one can be given safely as an outpatient initially, and that's the product that is most similar to the one that I was working on down at Fred Hutchinson. And so often that one we will give as an outpatient in the US. And basically what will happen is patients will then be admitted once they have that first fever or that first sign of CRS or neurotoxicity, and then managed in hospital until the side effects resolve and then discharged again. So that's where we may be going in the future with CAR T cell therapy. And when I say outpatient, I don't mean kind of you just show up at some doctor's office and have this infused and go home. These are very highly specialized centers where you're seen every day by nurses and physicians, even though you're, quote, outpatient. So it's similar to kind of what patients who have done an outpatient autologous stem cell transplant for myeloma would undergo. So we may end up going there at some point. From a logistics perspective in our system in Canada, it may be that initially we will be giving these therapies all as inpatient, just so that we can ensure that we have the beds available when patients need it, that they end up right on the ward that's specialized in administering these therapies as opposed to on kind of a more general medicine ward. So that's probably where it's going to start here in Canada. In terms of isolation, there's no particular isolation other than the typical kind of chemotherapy related things we recommend.
Thank you. I have one question. Is the patient's age a big factor? I would assume it would mean in success of CAR T treatment or even access to it.
So age does not seem to impact response rates or toxicity rates. So those who are older or younger do not seem to respond better or worse or seem to have any higher rates of CRS or the neurotoxicity. So age does not appear to be a factor, and that's one of the things that makes this therapy a bit more appealing compared to potentially some transplant options, or for example, in that they don't necessarily have strong age cutoffs. The oldest patient we treated at Fred Hutchinson with this was 76 years old. And I think they've treated patients who are older than that in the US. And I think I heard recently that somebody was over the age of 80 even. So it may not necessarily be as much of a barrier. Obviously, we are always concerned when patients are older as to their ability to tolerate chemotherapy, or if they get potentially an infection with low blood counts, being able to tolerate that. But it doesn't appear to be as significant an issue.
Thank you. Can ICANs and CRS overlap? Is it possible to have one or the other?
So typically, in the vast majority of cases, they do overlap, in that it's very rare to have a patient develop the ICANs without them having developed CRS first, or have CRS ongoing at the same time as their ICANs. What can happen, which is very interesting, is people can have an initial CRS event, say like on day 3 or 4, and then we give them tocilizumab, and then the CRS event goes away completely. So no more CRS. And then 3-4 days later, they develop ICANs. They develop the neurotoxicity with no CRS. And then we try to treat that, in that case, typically with steroid therapy if it gets severe, because usually the tocilizumab in that setting doesn't seem to work as well if the CRS has completely resolved. But they do go hand in hand quite a bit, and usually they go hand in hand with their severity too. So the higher the severity of CRS, the worse the CRS is, usually the worse the neurotoxicity is. There are very few cases where somebody can have a severe neurotoxicity with only a mild CRS and vice versa.
Thank you. Could it be that antigens that CAR T cells are designed to target on the cancer cells also be expressed on other cells like neurons or cells that comprise the blood-brain barrier?
So that's possible that they can be expressed on other cells, which is why I mentioned, for example, you get B-cell depletion. In terms of whether they're on neurons or the blood-brain barrier, CD19 is not expressed on any of those cells. They've done lots of studies looking at that, and there was initially some concern that maybe that's what might be occurring, but we have not found any evidence that is the case. Just to break down what is actually happening at the blood-brain barrier a bit from our research is that what happens is the endothelial cells and periocytes these are two cells that are vital for the blood-brain barrier. And so when the endothelial cells are exposed to high levels of these cytokines, they kind of open up and cause this thing called a capillary leak syndrome, which is where it suddenly there's normally these cells are tightly bound to each other side by side, and they suddenly open up and all those gaps form in between them. And so that allows a whole bunch of fluids and cytokines to flow down, and that hits the periocytes. And then those periocytes, in response to that as stress, they actually produce more cytokines. And one of the ones that they actually produce a lot of is IL-6, which causes this massive feedback loop, as I mentioned before. And then those periocytes kind of die off, and then or their spaces shrink down, and that means that gaps form, and the cytokines and the cells can enter into the brain space. So that's kind of more the blood-brain barrier disruption that we're talking about. Is it's occurring more on a level of the cytokines themselves, not on the CAR T cells targeting them. But for example, in developing CAR T cells against something like AML, one of the concerns is that there are a lot of antigens that are expressed on AML cells that are also expressed on endothelial cells. So we have to be very careful in the setting of acute myeloid leukemia, but we are working on developing, we being the general research community are working on developing CAR T cells for AML that are safe.
Thank you. I have actually a quite interesting question. How close are we to using donor T cells in the CAR T cell therapy process?
So I'll answer that in a couple ways. So one, in that we have already done that in the setting of somebody who's had a previous allogeneic stem cell transplant. Instead of obtaining those cells from the patient again, isolating those T cells, what we have done is gone back to the donor and get the donor to donate T cells, and then made CAR T cells out of those. And those seem to be working very well without causing any of that GVHD, as I mentioned. So we've done that already. In terms of getting more of healthy donor T cells that are more of like a off-the-shelf sort of product, there are multiple people working on developing this. Really, it's one of the hot areas that everybody is interested in. The main concerns there are twofold. One is that you could cause that graft versus host disease, as I mentioned, if those T cells come from somebody who's not compatible with the patient, or it can be that those T cells, those CAR T cells that are made, can be rejected by the immune system of the patient. So kind of two different ways of rejection here. So to answer the first question of where you're trying to prevent the donor cells from attacking the person's body, what people have been working on is removing the normal receptor that T cells use to recognize foreign cells, called the T cell receptor complex, or TCR, removing that at the same time that they're putting in the CAR. So they're removing the normal receptor and putting in the CAR at the same time. So that's one method that seems to be showing some promise. And then another method that is being used to look at the flip side of things is that part of how those CAR T cells are destroyed by the patient's body is that those CAR T cells also have what's called an MHC on their cell surface, which is a protein that the T cells use through their TCR to recognize other cells. And so you get rid of that receptor, you can actually hide them from the normal T cells of the patient's body. So you can kind of do it both ways. It's complex. Obviously, you can see as you go forward, if you're trying to put a CAR in, remove the TCR and remove the MHC, and potentially future products doing other things to them. Each of these manipulations requires more genetic material and more expertise. So we are working on it, but it is a little bit still in the future. But people have been presenting at conferences already about some of these approaches working, but we haven't, I haven't quite seen any responses yet in patients as we go forward, which is really what we're really is the end goal we're hoping for.
Thank you. I'd like to end this question and answer period actually with a statement. So one of our participants has said that he has received the CD19 CAR T cell treatment and is still cancer-free 1 year later. So that's always great to know that there's some people out there who are successfully doing well and who are listening to our webcast. So thank you very much.
That's great.
So I'd like to, just a reminder as well that we weren't able to get to all the questions, so we will do our best to answer those questions offline, so stay tuned for some emails that'll be coming out. I would like to finish off by thanking our sponsors for making today's webcast possible. So that's Novartis, Gilead, and Celgene. Also, I would like to remind everyone to not hesitate to contact us if you need more information. You can do so by calling toll-free or by email at canadainfo@lls.org. Also, be sure to check out our website regularly for the dates of our upcoming webcasts or even to watch all past webcasts. So please note that a short survey will be sent out to all participants after this webcast. We would really greatly appreciate you taking a moment to fill it in, as it would help us to better offer you some valuable information in the near future. So thank you very much for joining us, and have a wonderful day.